we're going to get into something that is, well, I think it's arguably one of the most important strategic developments in non-pharmacological psychiatry right now.
Oh, absolutely.
And that's the integrated approach, combining transcranial magnetic stimulation, TMS, with, really targeted psychotherapy.
Sure.
And we're not just talking about offering two services next to each other. It's about a genuine clinical synergy that's just redefining what's possible for patients.
Exactly. For those of you listening who are experienced TMS providers, you already know how powerful neuromodulation can be.
Of course.
But the next frontier, I mean, the real measure of success and, frankly, practice efficiency is that integration. Our whole mission today is to get past the theory and really unpack the tangible, measurable advantages.
Scientifically and operationally.
Both. How coordinating these two delivers deeper participation from the patient and, lasting improvement. It's the path to a complete model of care.
And before we jump into the mechanisms, the how of it all, we really want to thank the team bringing you this conversation. It's specifically for psychiatrists and providers who want to stay on top of these trends and the future of integrated care.
It's a fast-moving field.
It is. So a big thank you to the Blossom TMS team at www.blossomtms.com. They really get that clinical innovation starts with this kind of deep, integrated insight.
So when we talk about integration, I think we have to start with the core synergy.
Okay.
On the surface, the roles seem pretty distinct, right? TMS it's a bottom-up influence. You're adjusting the brain's electrical activity.
In places like the dorsolateral prefrontal cortex,
Oh.
the biological hardware.
The infrastructure, exactly.
Yeah.
And then psychotherapy, whether it's CBT or GBT, that's top-down. That's reshaping the thought patterns, the behaviors.
Cognitive software.
Perfect analogy.
So, okay, the additive benefit seems obvious, but I want to push on that idea of synergy versus just addition. Are we just seeing TMS take the edge off enough so the patient can finally engage in therapy? Or is there something more happening? How do we know TMS isn't just masking the issues?
That is the critical question. And the answer really lies in this concept of priming. It is genuine synergy, and we can actually see it at a cellular level.
Okay, so this isn't just a feeling.
Not at all. When you apply RTMS, you are inducing what's called long-term potentiation, or LTP, in those cortical networks. It's a process that increases synaptic efficacy.
It's making the pathways more communicative.
More communicative, and it makes new connections easier to form.
So if LTP is the key, what does that actually mean for the patient who's sitting down with their therapist, say, 30 minutes after a TMS session?
It means they are literally experiencing increased neuroplasticity. This is driven by things like the upregulation of brain-derived neurotrophic factor, BDNF.
BDNF, I've heard it called fertilizer for the brain.
That's a great way to put it. The brain becomes chemically and electrically more flexible, more ready to adapt. And this is the crucial part, more receptive to encoding new information.
So the skills they learn in therapy.
The cognitive restructuring, the emotional regulation skills, all of it is received and retained far more efficiently by the brain's circuitry.
Wow. I mean, that's a massive clinical advantage. You're basically shifting the brain from being stuck in a rigid depressive rut to a state of high receptivity.
Precisely. You're reducing the friction required for real behavioral change.
Which is the whole goal.
And that heightened state of learning brings us to, well, the scientific pillars that really drive this enhanced engagement and sustained effectiveness.
Okay, so let's unpack those. Pillar one has to be that neuroplasticity you mentioned.
Neuroplasticity and learning, yes. And for this audience, we know what the term means, but let's talk about it practically. How does this TMS enhanced state specifically accelerate therapeutic learning? We target the DLPFC for its role in executive function, right? Cognitive control. When TMS modulates this area, it doesn't just improve mood. It actually improves the patient's ability to do complex learning and self-monitoring.
The very things you need for therapy to work.
Absolutely. Psychotherapy depends on the patient being able to identify those maladaptive thoughts and then consciously replace them. When the DLPFC is primed, that cognitive heavy lifting, it just happens faster.
So are you saying that an hour of, say, cognitive restructuring post-TMS might have the impact of 2 or 3 hours worth of retention otherwise? Is that the idea?
That's the hypothesis, yes. You're maximizing the transfer of knowledge. We see patients generalize skills from the therapy room to their real life much faster.
They don't just understand the homework.
They're physiologically better equipped to do it. The engine is just running more smoothly. It can speed up the whole arc of treatment.
Okay, so if enhanced learning is pillar one, then pillar two has to deal with the emotional side, the thing that blocks learning in the first place. Emotional regulation.
Absolutely. I mean, think about the typical patient we see. Their emotional system is often in constant flux.
Total dysregulation.
Right. Overactivity in places like the amygdala driving that chronic anxiety.
Right.
While they lack that top-down control from the prefrontal cortex, it makes deep emotional processing almost impossible.
It's like the neurological foundation is constantly undermining the psychological effort. They're just too busy fighting an internal storm to process anything complex.
Exactly. And TMS, by modulating the DLPFC and its connected circuits, helps restore that inhibitory balance. We're essentially quieting the emotional alarm system.
So the outcome isn't just, I feel less depressed.
No, it's achieving better baseline emotional stability. This lets patients sit through difficult discussions, tolerate exposure work, and actually practice the skills they learn without getting overwhelmed or just shutting down.
It creates a feedback loop.
A very powerful one. Stability enables therapy, and therapy reinforces that biological stability.
That shift in tolerance for emotional discomfort, that's huge for long-term recovery.
Okay, so let's talk about the metrics that really matter to a practice. Pillar 3, motivation and adherence.
Ah, yes. The white whale of psychiatric treatment.
It really is.
And this is where the early tangible wins from TMS become such a powerful tool. You know, if a patient is only in talk therapy for chronic depression, it can take months before they feel a real shift. The dropout rates are high.
But with the combined approach, you're saying those shifts in energy and concentration, they happen faster.
Much faster. We're leveraging momentum. When a patient, after maybe just 2 or 3 weeks of TMS, says their sleep is better or they can handle stress a bit more, that tangible evidence reinforces the value of all their hard work.
It changes their mindset.
Completely.
Yeah.
It shifts from, I have to drag myself to all these sessions, to this is working and my participation is driving it. They become invested. Studies really suggest this combination significantly increases adherence to both treatments. That's a direct operational gain. Higher adherence means better outcomes, which supports practice growth.
And retention.
Okay, let's connect the science to the real world of a busy clinic. What are the clinical benefits beyond just, moving a number on a symptom score?
Well, for the practice, the first benefit is just a broader treatment reach.
How so?
By integrating, you can serve more complex patients, people with high comorbidity, deep treatment resistance. You're bridging that gap between biological and emotional processing. Your service becomes essential for the toughest cases.
And for practices that are tracking revenue, this holistic approach, I imagine it supports stronger arguments for reimbursement.
It absolutely can. You're not just treating symptoms, you're coordinating care for functional recovery. The second big benefit is stronger patient relationship.
And better attention.
And better retention. When care is holistic, patients feel seen as a whole person, not just a brain to be stimulated or a mind to be talked at. They feel it's more collaborative, less mechanical. That trust is invaluable.
And the outcomes themselves, they become more meaningful.
That's the key. We see the measurable improvements in energy and concentration, sure, but we also see those personally meaningful outcomes. The patient who successfully uses a skill in a family argument. The patient who finally completes a goal that felt impossible. The TMS lets the psychological skills really take hold.
This all sounds fantastic, but providers are stretched thin. Integrating 2 intensive treatments has to be operationally precise. So what are the common pitfalls, and what are, say, 3 actionable steps for a provider looking to really optimize this?
The biggest pitfall is siloed care. The TMS provider and the therapist operating in a total vacuum.
So the foundation is communication.
It has to be. Coordinated scheduling and communication. We have to move past the simple referral model.
Okay, so what does that look like on a Monday morning? Give me something concrete.
It means weekly interdisciplinary team meetings. Even if they're brief, even if they're virtual, it means shared, standardized feedback forms that allow a TMS tech to quickly note something about a patient's mood right before they walk into therapy.
So the therapist can use that information immediately.
And capitalize on that window of plasticity we talked about. It's a real-time feedback loop.
That synchronization is key to maximizing the priming. Okay, step 2.
Proactive patient education. This is non-negotiable. You have to clearly explain the synergy to the patient. Don't just say you're getting 2 treatments.
Explain the why.
Yes. Explain that the TMS is an electrical accelerant for the therapy. Tell them, we are preparing your brain to hold on to the insights you're about to learn. It turns them from a passive recipient into an active participant.
If they get the mechanism, they're more likely to commit.
Exactly. And the final step is committing to measuring outcomes over time. And I don't just mean symptom scores.
You mean functional engagement?
Right. Are they completing their assignments? Is their concentration better in section? Are they showing up consistently? This data proves the ROI of the combined approach and lets you adjust the TMS targets based on therapeutic progress.
It turns best practices into evidence-based practice.
It does. And if you connect this all to the bigger picture, the future for these complex conditions really is in this kind of integration. Isolating the brain from the mind is it's an outdated model. This offers a precision that goes far beyond just managing symptoms.
So what this all really means for you and your practice is that combining TMS and psychotherapy isn't just a promising idea, it's a strategic advancement. It results in superior outcomes for patients while also solidifying the value and integrity of your practice.
It truly brings together the power of neurobiology and the depth of psychological healing.
Indeed. And as you think about how to optimize these protocols in your own clinic this week, let me leave you with a final thought. It builds directly on that BDNF-fueled receptivity we discussed.
Okay.
If TMS really does maximize a patient's neural capacity for learning for that window of time right after a session, what specific intensified therapeutic assignments could you implement in that exact time frame to squeeze every drop of value out of that neuroplastic boost? Think about making that window of learning work harder for your patients.